So good morning, everyone. My name is Dr. Mahajan. I am one of the child and adolescent psychiatrists here at Kennedy Krieger Institute. I work at Center for Autism and Related Disorders. I've been here since 2008, but I'm also in other sites at Kennedy Krieger Institute, and I see some familiar faces from the other sites that I work at. How many of the attendees are family members or have family members? Okay. And I'm assuming the rest of the people there people who work with children with autism.
Family and profession.
Pardon me?
Family and profession.
Family and professional. Okay, good. So ADHD, how many people are familiar with ADHD? Okay, so that's very good. That makes my job easier. So I will be talking about ADHD symptoms. Typically, we talk about ADHD in children who are typically developing or who may not have developmental disabilities or who may not have autism. Over the past several years, there are many studies that have started to look at comorbidities in autism spectrum disorders. And one of the, perhaps the most common comorbid disorder, in addition to autism, is ADHD in children with autism, which surprises many people because people don't think about ADHD when they're thinking about autism. So I will try to give some background information and then talk about more specific signs and symptoms of ADHD and how do we approach the treatment, what are the medications that are used. Unfortunately, because of time constraints, I won't be able to go into a lot of detail, but we'll try to cover most of the ground. So these are the aims of the presentation. As I said, I'll discuss the concept of comorbidity of ADHD symptoms in autism spectrum disorder, and then discuss the evaluation of ADHD symptoms and then treatment options. And my focus will be primarily on medications, and I'm not going to talk about behavior management, which is a very important component of treatment in children who may have ADHD symptoms. So some disclaimers: I do not have any conflicts of interest. I'm not paid by any pharmaceutical companies to give any talks. I just work for Kennedy Krieger Institute. And this is a general discussion for educational purposes and is not meant to be any specific medical advice or advocacy for use of psychotropic medications. Every clinical situation is unique, and if you have a child who has any specific needs, you should discuss it with their treatment provider. I'm going to refer to some practice pathways that were recently developed. I was fortunate enough to participate in the framing of these pathways. I will refer to them, and there's a paper that Stacy printed for us that contains those practice pathways. So if you need to refer them again, you can do that. And there are two abbreviations that I'm going to use. ASD I will use synonymously with autism spectrum disorder and autism. And ADHD is attention deficit hyperactivity disorder. As I'd mentioned before, basically I will discuss background information, ADHD symptoms in context of ASD symptom evaluation, medications commonly prescribed for ADHD symptoms, and how we choose medications for ADHD. So I will start off by describing this clinical vignette. And this is a real patient that I saw here at Center for Autism. This was a 4-year-old boy who had autism and did not have any verbal communication abilities. So he came to me for a psychiatric evaluation, and the background history was that he had significantly disruptive behaviors. He was extremely overactive. He had severe impulsivity, and this included dangerous running, eloping, aggressive behaviors when mom or any other person tried to set limits with him. His mom was a single parent, and she was clearly overwhelmed when she brought him for this evaluation. Because we have a long waiting list, and this child was...
Sorry, there's a light right there.
Oh, okay, sorry. So because there was a long... She had put her child on the waiting list about 1.5 years before he was actually seen. And the interim, the child was having a lot of problems, so she took him to the pediatrician. So the pediatrician had some familiarity with psychotropic medications, so he started this child on 1 milligram of risperidone a day, which is debatable in a child who's 4 years old, and I'll explain that later. And progressively, it was increased to 4 milligrams per day over the next few months. Because the symptoms were not improving, mom decided to change the pediatrician, so she took him to another pediatrician who saw this child, who was not familiar with the use of risperidone, so he doubled the dose to 8 milligrams per day. And then the following month, because the child was still having behavioral problems, he increased it to 12 milligrams per day. So the maximum dose that I have seen in all the years of, that I've been practicing is about 6 to 8 milligrams a day. And that those kinds of doses are typically used in older adolescents or in adults. So he was clearly on a very high dose of the medication when I saw him. So I'll come back to what happened with this kid when, towards the end of the presentation.
Excuse me. Could you clarify what is risperidone for those of us who don't know what class of drug that is?
I'm going to talk about that in the presentation. Sure. So the concept of comorbidity in children with autism. So when we say comorbid, we are talking about more than one condition. So in context of autism, co-occurrence of more than one identifiable disorder in addition to the autism spectrum disorder is considered to be a comorbid condition. Sometimes we use the word co-occurring disorder instead of comorbidity, and we typically use them synonymously. So comorbidity is very common in autism spectrum disorders. They're until I would say until 2005, there were very few studies that had looked at comorbid psychiatric disorders in children and adolescents who had autism. There were some reports, there were some studies, but they were not very scientific. They were not based on measurement. They were just prevalence studies. Then in 2008, this study was by Siminoff et al. Was published in the Journal of Child and Adolescent Psychiatry, and this was a population-based study. And they found that in the population, 70% of the children who were diagnosed, children and adolescents who had autism, also had a comorbid psychiatric disorder. And this was considered to be a landmark study because prior to that, most of the studies were, they had looked at very small samples or data sets, maybe 50 subjects, at the most 80 subjects. So this was a big study and it had a big impact. Comorbidity in autism spectrum disorders depends on various factors. For example, the age of the child. Comorbid disorders can be, a lot depends upon what is the age that the child is being diagnosed, being seen at. We also see a pattern of emergence of new symptoms at different ages, developmental ages. So a child who's 5 years old may have a very different presentation than a child who's 10 and a child who's 15. So we have to have that developmental framework in our mind when we are evaluating children who have comorbid, who may have comorbid conditions. Comorbidity also depends upon the communication abilities of the child, such as language delays. Receptive and expressive children who have receptive language difficulties, they may present very differently as compared to children who have primarily expressive language difficulties. And I'll explain that later in context of the case I presented. It also depends upon the intellectual abilities of the child, whether the child is lower functioning versus high functioning, although that is debatable in some ways because some higher functioning children can also have significant comorbid psychiatric disorders. Co-occurring medical conditions, gastrointestinal problems, endocrine problems, neurological disorders such as seizure disorders, sensory difficulties, they can also affect the comorbid conditions. And then, if there's a family history of any psychiatric disorders such as anxiety disorders, mood disorders, they can also make the child more vulnerable. Psychosocial stressors such as parental stress, which is very common, can also affect the child and lead to development of comorbid conditions. And then the setting and context, where are the symptoms occurring or where are they being seen more frequently? That's another factor. And then the social demands. As children grow older, more is expected of them. And sometimes we see emergence of problems such as anxiety disorders as children grow older. 8, 9 years of age, you're in 3rd grade and there's a lot more expected of you and you just don't have the ability to keep up with that kind of demand, and then you can see emergence of some of these problems. The other thing is that children with autism may not fully manifest all the symptoms of comorbid disorders, and multiple comorbid disorders are very common. So you can have not just one, but more than one psychiatric, co-occurring psychiatric disorders, which makes diagnosing these individual disorders much more challenging. And most studies that have been done, they have shown that disruptive behavior disorders, which include ADHD and oppositional defiant disorder, to be the most common comorbid disorders. But in this study, they found anxiety disorders to be the most common disorders. And it is important to recognize the comorbid disorders because we have medications that can target these symptoms. So you have a child with core features of autism, which are used for diagnosis of autism spectrum disorder. In combination, or in addition to that, you can have all these problems, but a lot of these problems can be targeted using medications and or a combination of behavioral interventions and educational interventions. So this is a slide just to show that there is, when we talk about comorbid psychiatric disorders, there are many things going on. There are many factors that can play a role in development of a psychiatric disorder, and there is a disease vulnerability that may be shared by multiple psychiatric disorders. So moving on to the diagnosis of autism and ADHD. Are people familiar with DSM-5? So DSM-5 is the most recent classification, which was published last year, in which it's a diagnostic manual, which provides some guidance about, in regards to diagnosis of psychiatric conditions. And there have been many changes in DSM-5. We had DSM-4 TR prior to that. But basically, for autism spectrum disorder, as you may know, there was a big change that they removed all the diagnoses, the PDD, NOS, pervasive developmental disorder, Asperger's syndrome, autistic disorder. They are no longer used officially, and we use the term autism spectrum disorder. And basically, you need to have delays in social communication and restricted and repetitive behaviors to make a diagnosis. The other change they made was when the symptoms may manifest when the limited abilities are unable to keep up with the social demands. So they don't have an age criterion with that they had in DSM-4 TR. For ADHD, the two main categories of symptoms are the inattention, and the second is hyperactivity and impulsivity, and they tend to go together. So we treat them as a combination rather than separate symptoms. And the change they made was that the symptoms should be present before 12 years of age. In DSM-4, which was the previous classification, the symptoms should have been present before 7 years of age, so that's another change. One great thing that happened in DSM-5 from our perspective is that they now, and I'm sorry it's not very clear, but this highlighted, what this indicates is that they allowed us to make a comorbid diagnosis of ADHD in autism spectrum disorder, which is very ironic because we've been treating ADHD symptoms for years in children who are on the autism spectrum, and yet we couldn't make a comorbid diagnosis. So now we are officially allowed to do that. So this is just to show this is some more background information. When we work with children who have, let me go back to this slide. So the other change that happened was, this is the category of neurodevelopmental disorders. So ADHD was in a separate category in DSM-4, and now it has been included under neurodevelopmental disorders in combination with intellectual disability, communication disorders, and autism spectrum disorders. So that is very significant because we think of ADHD as, we've been treating ADHD as an neurodevelopmental disorder for a very long time. So they are recognizing that in DSM-5. This is to show the differences in trajectories of brain development, how the brain is developing. So if you see, this is the age and this is the size of the brain. And this slide is for ADHD, this is for autism. Children with autism, they have been found to have a very specific brain trajectory of development. So they at birth, their brain size may be, and this is in comparison to children who are developing typically or who may not have autism or ADHD or may be considered to be normal. This says normal, it should be typical actually. So as children grow older, children have been found around 6 to 14 months of age, there is a sudden spurt in the size of the brain. So the brain volume, the thickness of the brain cortex, that increases. And it actually goes into, this is considered to be an overgrowth. And it's generalized. It involves certain regions, but overall, children with autism can have a much larger head circumference and brain size as compared to typically developing children. So around 8 to 9 years of age, there is a plateauing of the brain development, so the size kind of stabilizes. And as children move into adolescence, there is a decline in the brain development. And some studies that have been done in adults, they have found that the brain size actually might shrink as compared to a person who does not have autism. Now in ADHD, this study was a landmark study that was done at National Institutes of Health, and what they found was that children with ADHD have a smaller brain in size as compared to typically developing children, and it was primarily because of the thickness of the cortex. Cortex is the outer layer of the brain, which may include the gray matter, which contains neurons or as well as the white matter. So what they found was, the good news was that they found that by 18 years of age, children, about 50% of the children, they were able to catch up with typically developing children. So there was, what this suggested was that there was just a delay in cortical maturation, at least in 50% of the children. So, but the question is, you know, these are comorbid conditions, and what happens to the brain development when ADHD symptoms are co-occurring in the setting of autism, and we don't have answers to that as yet. So, as I said, you know, I've already talked about this. So in ADHD symptoms, as I said, they are very common in children with autism. So hyperactivity, impulsivity, and inattention, they're very common. Several studies have been done over the past several years. They have used scales to measure ADHD symptoms, and most studies have found the prevalence to be between 40% to 50%, that's the average. But there are some studies that found that the rates could be as high as 78%. There was a recent study done in 2012, they found a rate of 16%. So there's a huge variation because it depends upon different factors, the sample that is being, the children who are participating in the research, whether they're high functioning, low functioning, those kinds of factors can play a role. And there's a potential, some studies have shown that there might be shared genetics between autism spectrum disorders and ADHD. And people have been asking this, they've started asking this question, that when children have both ADHD and autism, is it a separate condition in itself? Is it a type of autism that is distinct from the rest of the autism? So is it a separate phenotype? And as I said, the recognition and treatment of ADHD symptoms is complicated because of the multidimensional nature of disabilities. There are so many things going on, such as cognitive delays, communication delays, and you can have other comorbid conditions in a brain that is developing differently. And this is just to show the same slide that you had seen earlier, that both autism spectrum disorder and ADHD, they were found to share some genetic mutations or changes in the genetic makeup, so this might be another evidence for disease vulnerability, common disease vulnerability. So now, as I said, ADHD symptoms in context of autism is a new topic, and people, pediatricians, neurologists, psychiatrists, we've been treating children who have just ADHD for a long time, and medications have been available for decades. There were best practices, guidelines have been available for treatment of ADHD from organizations like American Academy of Pediatrics, American Academy of Child and Adolescent Psychiatry, and these have been updated. So we have recent guidelines. And there are guidelines for screening and evaluation of autism from American Academy of Pediatrics, and evaluation and treatment from the American Academy of Child Psychiatry. Actually, this, I haven't updated it, but they recently came out with updated guidelines for autism spectrum disorders. But there are no guidelines for children who have both ADHD and autism spectrum disorder. As I had said, the prevalence of autism has increased recently. They came out with a new number. I think it's 1 in 64 children. That's what the CDC numbers. But interestingly, what the most recent numbers also what the most recent report also indicates is that there's been an increase in number of children who are much higher functioning, or children with high functioning autism. And some of those children, maybe 10, 15 years ago, they were not diagnosed with autism, and they were being diagnosed with ADHD rather than autism spectrum disorders. So the concept of autism has also changed, which has led to increase in this diagnosis. The other thing is that now we have a lot of medications, a lot more choice of medications as compared to maybe a decade ago. And we have a better understanding of how these medications work. And they are being used frequently. So if you have a child who is on the autism spectrum and they have a comorbid condition such as ADHD, anxiety disorders, or mood disorders, they may be on multiple medications. Psychotropic medications can be very beneficial in reducing the suffering of the child and of the family, but they also have a lot of risks. So, that is another reason we needed guidelines. And the clinician who is treating the child, it also depends upon how familiar they are in working with children who have developmental disabilities, who have autism spectrum disorder, and with comorbid conditions. So the clinician factor can also play a role in whether how well the child does. There was a recent study that found that about 50% of children children and adolescents who've been diagnosed with autism, they take a psychotropic medication. And medication use is more likely in setting of limited intellectual ability, when children have lower adaptive skills, if they have more deficits in their social skills, the communication status, physical issues, for example, body size, physical size. So a child who is 6 feet 5 inches tall and weighs 350 pounds and has aggressive behaviors may cause more damage as compared to a child who is 6 years old, is much smaller in weight and size. So these issues are also taken into account when we prescribe medications. So, and then, as I said, seizure disorders are common, and the psychosocial and educational issues. When we prescribe medications for ADHD symptoms, basically they target these receptors, dopaminergic receptors and noradrenaline or noradrenergic receptors. So I'll quickly go over, this is a brief description of the medications, and then I will talk about how we choose medications. So
I'm sorry, do you have that slide?
I actually changed the slides a little bit, so I apologize for that. Some of these slides are available at the end of the handout. So stimulant medications are medicines such as Ritalin. I'm sure everyone has heard of Ritalin. Focalin, Adderall, Dexedrine, Vyvanse. So these are considered to be the first-line medications for treatment of ADHD. And they act on the dopaminergic and noradrenergic synapses in the brain, and they improve inattention, reduce hyperactivity, and impulsivity. So they they are beneficial for all three categories of symptoms in ADHD, in a child who has ADHD symptoms. And this is a recent study that was just published, which also found that, which also indicates that they may improve emotional regulation, which is a big problem in some children who have ADHD symptoms. We also take into account, so these two medications that are in red, they are they belong to the Ritalin family. And these 3 medications, they belong to the Adderall family. So there are these 2 major families of stimulant medications. So we start with a medication from one family. We try a couple of medications or 3 medications. If the symptoms are not improving, then we go to the other medication from the other family. And there are common side effects, things like reduced appetite, stomach aches, headaches, insomnia, unmasking of tics. They don't cause tics, but they may unmask tics in a child who has the vulnerability to develop tic disorders. There's a question frequently asked whether the child needs an EKG if they are being considered for a stimulant medication. And the current guidelines from American Academy of Pediatrics, they don't recommend routine baseline EKG, but if there are any predisposing factors, such as a family history of heart problems or somebody dying at a young age due to an unknown cause, or the child has a genetic heart problem, then an EKG is essential. They have side effects, other side effects such as anxiety, irritability, and they can also lower the seizure threshold. So children who have seizures in addition to autism, you have to be very cautious. So some neurologists, they don't say don't prescribe the medication, but they are very cautious when they prescribe stimulant medications to children on the autism spectrum. Alpha-2 agonists are the other group of commonly prescribed medications, and these include clonidine and guanfacine. And these are the brand names. Catapress is the immediate release. Capvay is the extended release form of clonidine that is used. Tenex is the immediate release preparation, and this Intuniv, which I'm sure you must have heard about, is the extended release preparation. So these medicines, they act centrally in the brain, and they lower the central adrenergic drive. And what that does is that reduces the hyperactivity and impulsivity. So the child is calmer, they have better impulse control, they are able to sit still, but they don't affect the attentional problems. So the child may still have problems staying on task, focusing, they may still get distracted if these medications are used first. And these medicines have been used for years as blood pressure medications in adults. So the blood pressure and heart rate should be monitored at least for a few days when a child is started on one of these medications. Typically, we recommend maybe 3 days or 4 days. Or if the dose is increased, then you might want to monitor the blood pressure and heart rate. And they are frequently combined with stimulant medications, and typically we use them when the stimulant medications are unable to reduce the symptoms of hyperactivity and impulsivity, or if the child has aggressive behaviors. They can also be prescribed independently. So children who have mostly hyperactivity and impulsivity, they can be started on these medications before being prescribed stimulant medication. And some children do well on just clonidine and Tenex. You may have heard of atomoxetine or Strattera. Atomoxetine is similar to the older antidepressant medications in its structure and mechanism of action. It also acts on both dopaminergic and noradrenergic receptors. But it's different from stimulants and alpha agonists in that you may not see the effects of the medication right away. So it has to build up in the system. So it may take 3 to 4 weeks before you see any kind of benefit from atomoxetine. So that's a drawback of this medication. But the advantage of Strattera is that if a child has severe co-occurring anxiety and they're unable to tolerate the stimulant medications, then then the child can be tried on atomoxetine first instead of the stimulant medications. But again, like all psychotropic medications, atomoxetine has a lot of side effects. sedation, irritability, mood swings, lowering of appetite, and EKG may be needed if there are predisposing factors, just like with stimulant medications. I personally don't use a lot of Strattera because of these problems. A lot of children, they have mood swings, irritability, and anger problems, and you stop the Strattera and some of the symptoms improve. So, but it's still considered to be useful for ADHD symptoms. And the last group is the antipsychotic medications. These are atypical antipsychotic medications. These are risperidone and aripiprazole. These are the two FDA-approved medications for treatment of irritability in autism spectrum disorders. They act on the dopaminergic receptors. Risperidone is similar to the older antipsychotic medications, if you've heard of Haldol, Thorazine. So in its effects, it's similar to the older medicines, but it has fewer side effects as compared to the older medications. Aripiprazole acts in a different way, but some children, they do well on aripiprazole. Some children respond better to risperidone. So typically we start with risperidone. Now, the important thing is that we don't typically start, like the child that I described earlier, we don't typically start children on risperidone. They are not the first-line medications. We use these medications in the setting of ADHD symptoms if there are safety concerns, such as aggression, if there is severe impulsivity that the child, in spite of being on stimulants, alpha agonists, they are still having severe impulsivity, including impulsive running, jumping, etc. That would be a reason to try or add antipsychotic medications. They may also help with regulation of mood. These medications, they have a risk of side effects, and that's the main reason why we try to not use them as the first-line medications. So sedation, tiredness, increased appetite, weight gain, high blood glucose, high cholesterol levels, all these are very common symptoms, and we monitor children for them. The other group of symptoms that we monitor children for are the so-called extrapyramidal symptoms. These are movement disorders and tardive dyskinesia. Are people familiar with tardive dyskinesia? Okay, so tardive means slow in onset. Dyskinesia is abnormal movement. And we monitor children for emergence of these unusual movements, and typically they may involve, these are repetitive movements of the tongue, of the face, or they may involve other parts of the body. And they emerge after a period of time. So you may not see them for a few months, and the child does well on the medication, but then you might see sudden twitching movements around the mouth or of the tongue, or the tongue is going in and out of the mouth. So you should think about this and immediately contact the prescribing physician. This side effect has been in the news a lot. You might have seen, you have a phone, you have a lawyer kind of ads where they're talking about gynecomastia, which is breast tissue development in children, in boys. And in girls, you can have menstrual irregularities, or you can have complete stoppage of menstrual periods. One thing I did not mention here is a side effect called galactoria, which is production of milk in girls. So that can happen too, and if that happens, then we have to stop the medication. Atypical antipsychotics can also affect cardiac heart functioning, and if somebody's on multiple medications, then we also get an EKG just to make sure there are no problems with heart problems. So this is the article that was published in Pediatrics. It talks about with all the background information that we had, and we did not have any kind of guidelines or practice pathways, and it was directed towards primary care physicians, towards psychiatrists, neurologists, clinicians who work with children who are on the autism spectrum and who may be prescribing medications for ADHD symptoms. And it was under the auspices of Autism Speaks, Autism Treatment Network. This is a network of, I think it's 17 academic centers. And basically, are you familiar with ATN, Autism Treatment Network? So these 17 centers have kind of collaborated, pooled the resources, which includes people who are doing research or clinicians who are working with children with autism spectrum disorders to create guidelines for other clinicians who may be working with or to standardize the treatment of the co-occurring disorders or treatment of autism itself. So I was a member of this committee, medication choice subcommittee, where we are working on different presentations or symptoms that children are prescribed medications for, and we chose ADHD as the first condition to target because it's so common. And we conducted a systematic literature review. We studied, we reviewed all the clinical trials and studies that were available for treatment of ADHD symptoms in children with autism spectrum disorder. And we came up with two practice pathways. The first one was symptom evaluation pathway, and the second was medication choice pathway. And I'll quickly go through these. We basically looked at what are the indications, what are the reasons, why would somebody prescribe a medication or when to prescribe a medication for ADHD symptoms in autism, and what are the side effects of these medications. And we focused on these commonly prescribed medications. And we studied around 1,200 articles, studies that had been published, and we came down to 31 articles that met our criteria for inclusion in the study. And do people know what randomized controlled trial is? So this is a gold standard of any clinical trial in which it's called the double-blind placebo-controlled trial. There are other types of randomized controlled trials, and basically these are considered to be better studies than studies that may not be randomized controlled studies. So we found that there were only 15 randomized controlled trials. So all these years that people have been prescribing medications, there were only 15 studies that met the criteria for the gold standard, for a gold standard study. So there were only 3 studies for stimulant medications. And one of them was a study done in preschoolers. And for Strattera, there was just one study. I think there's a new study that came out recently. For alpha agonists, there was one study, and that was using guanfacine. And most of the studies were actually done for the antipsychotic medications. And for example, for risperidone, there were 5 studies. Aripiprazole or Abilify, there were just 2 studies. And there were some other studies that these are not standard treatments for autism spectrum disorder, but there were randomized controlled trials for these studies, for these medication combinations. So this is the practice pathway. If you look through the article, this was for the symptom evaluation, and I've covered most of the what's described in the practice pathway, but basically it begins with a comprehensive evaluation of the child. And the important thing is that both the diagnosis should be confirmed. So a child who is, if you're taking a child to a provider, you need to make sure the child actually has autism spectrum disorder before we say that these ADHD symptoms are occurring in context of autism. So both the diagnosis should be confirmed. And that may require use of scales. You might be familiar with Connor's scale or Vanderbilt scales. And these are scales that are sent to the school. Parents fill them for home. There's some other scales that are used. And multiple informants are necessary. So because one of the diagnostic criteria for ADHD symptoms is that the symptoms should be present in more than one setting. So if a child is having problem just at home or just at school, then it may indicate a different problem than just ADHD symptoms. Other causes should be ruled out, such as medical comorbidities, cognitive delays, speech and language difficulties, sleep problems. Insomnia can affect focus and concentration of the child. Other mental health comorbidities, such as mood disorders, anxiety disorders, they should be ruled out. Educational interventions are typically tried first, and when we talk about treatment of autism spectrum disorder, the first line treatment is educational intervention. So modifying the environment at school. The child may need a Section 504 plan or an IEP in place in school. And we also recommend trying behavioral interventions both at school and home before we think about trying medications. Sometimes we recommend in-home services depending upon the situation. So medications are only used if other interventions are in place and the symptoms of ADHD are persisting. And if in spite of all these interventions, symptoms are persisting, then the child should be reevaluated or reconsidered. The diagnosis should be reconsidered. This is the medication choice pathway, and it basically describes how we choose medication. So this box, when we have a child, we have tried everything and nothing is working, and we are going to medications. We start with the stimulant medications just because we have used stimulant medications for a long time. These are the first line medications for treatment of ADHD symptoms. And they may be beneficial for all three categories of symptoms in ADHD. If these don't work, then we move to the next category, and typically it is alpha agonists, so clonidine or Tenex. Yes?
So when you were referring to stimulants, I know that you talked about there being two families. Is there one that you usually start with, or is there a large difference between the two families?
So that's a good question. So we typically, what we recommend in this paper is starting with methylphenidate, because there is one study that was done. There were 3 studies with that have been done with methylphenidate, but we don't have any studies with Adderall or amphetamine families of medications.
And do you notice different side effects, different effects?
No, we treat stimulant medications to be similar in all respects.
So
But that's a good question, though.
So you wouldn't start Ritalin and then change him to Adderall if the Ritalin wasn't working?
We typically do it if the medication, we try more than one preparation. So there are 2 medications. So the other is the Focalin, and if Ritalin doesn't work, then we think about Focalin. It also depends upon what we are using, and typically we start with immediate release preparations rather than extended release preparations.
Mm-hmm.
So because that can also affect, extended release preparations tend to cause a lot more side effects as compared to immediate release preparations. Mm-hmm. So then we try the alpha agonists, and we can, depending upon the situation, either add it onto the stimulant medication or try them independently of stimulant medication. Alternatively, you can also try Strattera, depending if there's a lot of anxiety.
Do stimulants generally, as a group, react the same way in children? In other words, is there a big difference between how one stimulant reacts as opposed to another stimulant?
We don't treat them as being different. They have similar side effect profile, but some children respond better to one stimulant as compared to the other. We don't know why. And so we start with stimulants and then try alpha agonists or atomoxetine, and then if they don't work, then we go to antipsychotic medications. And this flow chart, if you look at the bottom, it gives other criteria for choosing these medications. So I think I've covered most of these topics. So, I just want to emphasize this. So when you take your child to see a provider for ADHD symptoms, this is very important. So the discussion is very important because you want to set goals for treatment. You want to have a clear-cut idea of how long are you going to keep the child on the medication before you say it's not working. So you have to set the target, and what are you targeting? Are you targeting inattention, hyperactivity, impulsivity? What are the risks and benefits? I mean, these may be, some children may just be more sensitive. Children who are on the autism spectrum, they tend to be more sensitive to side effects of medications in general. So what doses are you going to start with, and how fast are you going to increase those doses? And at each visit, the effectiveness and safety should be discussed. And if there is any kind of worsening of behaviors or you're seeing something abnormal, immediately contact your provider to discuss that. If we recommend that if the primary care clinician or provider is not sure about the diagnosis, they should seek clarification. They should refer the child to a specialist. Could be a neurologist or a psychiatrist who specializes in diagnosis in children. Or if the therapy that is being prescribed is ineffective, then children should be referred. So going back to, I think we are almost out of time, right? So the case illustration, so that boy, so I saw him for the psychiatric evaluation, and I literally fell off the chair because I hadn't seen those kinds of doses being prescribed to any child, and this was a 4-year-old kid. So we gradually decreased the dose to 1 milligram per day. So we had to go down from 12 milligram to 1 milligram per day. It took us 6 or 7 months to do that. And over that period, we also added an alpha agonist and low doses of stimulant medications. So there was some improvement in the symptoms, but not a whole lot. Concurrently, the child was also referred to behavioral psychology clinic for behavioral interventions and speech and language evaluation and therapy. And mom was referred for a social work evaluation because she was dealing with a lot of stress. So that's the presentation. So these symptoms may cause significant impairment in children with autism. And these pathways can provide guidance, but every clinical situation is different. So these are general guidelines. Stimulants should be used first before atypical antipsychotic medications. So if I had seen this child, I would have thought about behavioral interventions first before thinking about medications, or I wouldn't have prescribed risperidone to begin with. And we need a lot more research in this field and to understand the co-occurrence of ADHD and autism spectrum disorders. And especially a lot of clinical trials are needed to evaluate these medications for symptoms in ASD. And we have somebody here who is actually involved with research and a lot of clinical trials at Kennedy Krieger Institute. So that's it. So that's the presentation.